Hi, welcome to Orlando. I'm Maria Fleseriu. I'm a professor of medicine and neurological surgery and director of OHSU Northwest Pituitary Center at Oregon Health Science University. I have been talking about acromegaly for a long time, but now we really have new excitement in the medical treatment. When I meet a professor at this Endocrine Society meeting, we covered in detail the updates on medical management of acromegaly. For acromegaly, we still have problems with late diagnosis. Sometimes the delay of diagnosis is up to 11 years. Thus, patients present very frequently with a lot of symptoms and also, unfortunately, large tumors. For most cases, surgery remains the first line of treatment. However, due to the fact that patients have, as I said earlier, large tumors, most of these patients will require medical management. Some of the patients, per guidelines, will also require radiation as a third-line therapy. Let's talk a little bit about the medications that we have available. And when we group how the medications will work, several of them will work at the pituitary level to decrease the growth hormone, and I will cover them in detail later. And then one drug that blocks the receptor, it's a growth hormone receptor blocker. Talking about the drugs that work at the pituitary level, we have octreotide LAR and lanreotide that we have them for several years now. Fleseriu LAR has been approved much later, and it's a different type of somatostatin receptor ligand that also works at the pituitary level, but just binds to more receptors, especially type 5, thus increasing the efficacy with about 25% of cases. Due to the mechanism of action, Fleseriu also induces hyperglycemia in a large number of patients, so it's important to know this and also to know how to treat, if it's really needed a drug, how to treat the hyperglycemia associated with it. The growth hormone receptor blocker that we are, pegvisomant, that we have also for several years, now we have more data that if we're using the right doses, we can control more patients. It's essential to know that because in most recent study, overall, the ACRO study, the control rate was lower than we expected. But when we looked at the doses between uncontrolled patients and control patients were about the same. So increasing the dose, the same for somatostatin receptor ligand, shows that we can control with pegvisomant too, as in the initial study, most of these patients. We also have now more and more data on combination therapy. Though they are not FDA approved, they are used more and more. Most of frequent combinations are between somatostatin receptor ligands and pegvisomant. Also few data between somatostatin receptor ligands and cabergoline, and after that very few data, but there have been patients treated between cabergoline and pegvisomant. So we're a new era of combination therapy that hopefully will increase both efficacy that we have seen and reduce the adverse effects and hopefully also the cost. There are also several other drugs in development, and it's always exciting as a researcher to look at the landscape and see how many are coming down the pipeline. And that's important because, as I said earlier, the patients are late diagnosed, they have a lot of symptoms. It's important to look and to try to improve the quality of life. Oral octreotide is a drug that is in a phase 3 clinical trial. One was completed, several are ongoing. So this would be important because the patients can get off injections and take oral medication if this will work for them, and if the drug will get approved. There are also some other long-acting in trials, and they have been presented as a poster for lanreotide to expand the interval even more than the 6-8 weeks that they are approved right now. We know that there are some other drugs in development with different mechanisms that hopefully will, in preclinical trials, that will hit more receptors with less adverse effects or other forms of mechanism at the growth hormone receptor level. So overall, a lot to cover in this time, but we are pleased that the area of research in medical therapy is moving. It's never moving where I would want to be or with the speed that I would want to be, but still it's exciting to be again an endo and talk about acromegaly.